I've come to talk about the SHED study, which is hopefully starting very soon, which will be running over the next few months in A&E. So the SHED project is one that's been passed on from a couple of my predecessors down the line, and has been much delayed, but it's the subarachnoid hemorrhage in the emergency department study. So to run through what we'll talk about, so first of all, we'll introduce it. What is the SHED project? We'll talk about why it's needed, why we're doing the project, what the objectives are, who we're planning to recruit, and how, what the consent process will involve, and how people and how particularly clinicians and care providers that we hope can get involved in enrolling people into the project. So what is SHED? So it's subarachnoid hemorrhage in the emergency department. It's a prospective study. It's multi-centre, and I think there's about 100 centres that are involved across the UK. And the aim is to recruit consecutive adult patients who present with severe non-traumatic headache, with the objective to externally validate a 6-hour CT brain rule-out strategy for suspected subarachnoid hemorrhage. By way of background, so acute headache is a very common presentation in the emergency department. It can account for about 1 to 2% of presentations at EDs across the UK. And of those, a significant proportion will have serious pathology. The pathology in particular that we're ruling out with severe sudden onset headache, and specifically with these people, is subarachnoid hemorrhage. And it's a diagnosis not to be missed. It carries significant morbidity and mortality. And as a result of that, historically, these patients have gone on to have high rates of invasive investigations. The previous sort of pathway through the hospital for all of these patients would be a CT brain scan and generally speaking also a lumbar puncture to confirm or rule out the diagnosis of subarachnoid hemorrhage. Increasingly over the last few years, there has been a move to reduce the number of lumbar punctures that we've been performing. There have been studies that have been looking at the sensitivity of plain CT head in isolation, and the results of those studies have been reasonably positive in that they show that CT head scans have got a pretty good sensitivity in picking up the diagnosis of subarachnoid hemorrhage without any further investigations. And so lots of sites, including our own, our current NHS Lothian pathway for acute severe headache includes a 6-hour CT head rule-out strategy, but there's not been any, there's not been any external validation of a 6-hour CT head rule beyond the studies that have been done in isolation of the CT scans. So the study has been set up to externally validate the 6-hour CT brain rule to say, okay, well, if their CT head scan performed within 6 hours of the onset of the headache is normal, can we safely discharge these patients without putting them through further investigations, without putting them through lumbar puncture? So objectives, so the primary objective is to externally validate a 6-hour CT brain rule-out strategy. And that is specifically with alert patients, acute non-traumatic headache, and clinical concern for subarachnoid hemorrhage. There are a couple of secondary outcomes, one of which is to validate this Ottawa subarachnoid hemorrhage rule. So that's a clinical decision rule. It's got 6 points in it with clinical features. And it's been suggested as a clinical decision-making rule to suggest that people without any of the positive findings in their clinical assessment don't need to go on to have any investigations at all, including not needing a CT brain scan. And again, the Ottawa clinical decision-making rule does feature in our local guidelines for managing subarachnoid hemorrhage, but again, hasn't been externally validated in a UK population. To understand the change in the sensitivity of CT imaging in patients that are in that window after the 6 hours, so the 6-hour number comes from some of the primary research from the radiology journals that suggests imaging within 6 hours of onset of the symptoms. But there's not really any understanding of why after 6 hours that sensitivity would deteriorate, and even whether or not it does. So we would also look to ascertain that, and also to report the prevalence of subarachnoid hemorrhage in patients that are under the age of 40. So study design, so it's consecutive patients attending the emergency department. The recruitment is planning to be 24 hours a day, 7 days a week. And the inclusion and exclusion criteria will come on to, but the inclusion criteria is deliberately very broad to try and catch as many patients as possible. The information that we gathered is from a review of the patient's clinical records. So from this site, it will be clinical information that they attend with at the time, and then clinical information from their electronic patient records, so their clinical notes essentially will give the information that's required, the data that's required to input into the study. So we record the information at the time of recruitment, between 24 and 72 hours after they present to the department, and then following up at 28 days. And the 28-day endpoint is to determine whether or not they have subsequently been diagnosed with subarachnoid hemorrhage in that time. So if they've been discharged with a normal CT head scan, but then subsequently been diagnosed at any point within the next 28 days with subarachnoid hemorrhage, then that will be identified through a clinical note review at 28 days. So participants, so people that we're looking to include, so this is adult patients, so anyone aged 18 and above, anyone that presents with an acute severe headache, who is alert and has a headache which reaches maximal intensity within 1 hour. The sort of definition of these headaches is a little bit variable, and some places talk about reaching maximal intensity within an hour. The Ottawa rules include instantaneously reaching maximal severity, but the 1 hour window has been chosen again to cast as broad net as possible. We're trying to pick out the patients that have headache which reaches maximal intensity very quickly. Exclusion criteria, so listed here, but patients with trauma, patients with a known subarachnoid hemorrhage, or previous hemorrhage, brain cancers, recurrent headaches of the same nature again will be excluded, and some other exclusion criteria which are there. In terms of recruitment, so as I was saying, so it's a nationwide project, and the goal is to recruit 9,000 patients in total across 100 sites, and we're aiming to recruit 90 patients from our 2 sites. So Royal Infirmary and St John's will be the 2 sites that we're operating, and we're hoping to recruit 90 patients. We'll be running for 4 months, so hopefully we'll be able to recruit the numbers in that time. We'll be recruiting 24 hours a day, 7 days a week. Anyone that's care providing for a patient can recruit people into the study if they meet the inclusion and exclusion criteria. And I'll come on to go through some of the paperwork that we use to recruit people into the study for there, but it's fairly straightforward. What we hope to do is to recruit patients prospectively, i.e. from the point that they're in the emergency department presenting, we want to present them with the information and the patient information leaflet and get them recruited in at the time. However, there is scope for us to go back and recruit people retrospectively as well from a trawl of the track data that's been accumulated for that previous day. The consent process has been made as straightforward as possible. It's a study which doesn't alter a patient's standard care at all, and therefore it's been deemed that there's not a formal consent process that's required, and consent is done on an opt-out basis. So everyone that's been recruited to the study is being given an information leaflet that explains to them that their anonymized data will be included in the study, that the study won't affect the care that they receive, and that they have an opportunity to opt out if they don't want their data to be included in the study. Everyone will be presented with that information at the point that they present to the department. And for those that are retrospectively included, they'll be given that information by mail. There'll also be some study information posters on display in the waiting room and around the department, so that it's advertised to patients as they are in the department as well. This is some of the paperwork, so hopefully that's presenting okay. So on the left is the patient information sheet. So that's one half of a, it's two sides of A4, so it's a single piece of information. But that goes to the patient that's got information on what their data is going to be used for, what data is going to be included, the fact that their care isn't going to be altered, and what the process is for opting out if they choose to do so. And on the right is the checklist for inclusion into the study. So at the top here, I don't know whether you can see the cursor, but at the top there's two inclusion criteria that we want the patient to meet. So being over the age of 18, and then having that acute severe headache which reaches its maximum intensity within the hour. And if they meet both of those criteria, then they are of interest to the study. We're also looking to collect the rest of the clinical information, and again, that's the clinical information that we want from the treating clinician at the time. So presence or absence of any of these clinical features, which is important for data collection and interpreting the data, but these aren't inclusion criteria below here. These are just the clinical features that we want to be familiar with. So for the treating clinician, there's this one page of A4 with tick boxes to complete, plus giving the information to the patient, presenting them with the patient information leaflet. These two will come stapled together, and they've got a unique identifying number at the top of each one, so that when the patient's recruited, we'll know that the information sheet that they've been given matches the number that is on the checklist that's been completed by the care provider. So for the care providers, for recruiting them into the study, the burden and the workload is hopefully fairly small, and it's just those two bits of paperwork that we need to be processed by people that are taking part and by people that are recruiting patients into the study for. So what we're hoping for from you, so for the care providers and for the clinicians that are treating these patients, we want you to be involved. We want you to help us to recruit patients as much as possible. So I think we're going to run for several months. So we'll try and keep reminding people, but having an awareness that the study is going on, and to bear people in mind when you see these patients on the shop floor, are they or are they not eligible to be included in SHED, and all of these all of these things will come back to the study team that will then be able to determine whether or not they're included. So remember to include them and recruit them into the study at the time if you can. If for whatever reason you aren't able to do it at the time, then making sure that the relevant clinical information is recorded in their EPR, so that if we're looking back retrospectively, then we're able to determine from what you've recorded in the notes whether or not we can include them in the study. And for anyone that's interested in becoming more involved in the team, we've got a few of us that are on the study team now, but always keen to hear from anyone else that is keen to join the study team as well. And if there is anyone out there that's keen to be more involved, in getting in touch with myself to join the study team, and we can we can do with some extra help in terms of processing the data and so forth.